Thanks very much for joining us on this another edition of a weekly research conference. And we're delighted today to bring you some really hot off press data. And just a few logistics, if you have any questions for our presenter, please use the Q&A feature on the bottom of your screen. And you can do this as the lecture proceeds, and we will be able to take the questions at the end of the presentation. And also, if you are interested in asking the question directly, please feel free to do so as well. And you can use the hand up feature, and then we'll unmute you, and you can directly ask your question to our presenter today. And but on the other hand, if you have any technical issues, please use the chat function, and then Kelsey or Allison will work with you to make sure that you can join us very effectively. And today we are absolutely delighted that we have Dr. Derek So to present for us some of the stories of very exciting projects he's been doing, including some of the latest clinical trials as he just presented at American Heart Association. And Dr. Derek So is a clinical investigator with us here at the University of Ottawa Heart Institute, associate professor in the Department of Medicine at the University of Ottawa. He's also program director of the adult interventional cardiology program here at the Institute, and he leads the regional strategic research innovation on the percutaneous intervention strategies. And Dr. Derek So earned his medical degree at the University of Toronto, and certainly remember him well. And he did his residency in internal medicine at McMaster University, and subsequently cardiology at University of Ottawa Heart Institute, and subsequently fellowship training in interventional cardiology. And he also furthered his training with a master's in clinical epidemiology at the Harvard School of Public Health. And his research has been funded by Heart and Stroke Foundation, CIHR. Is a reliable reviewer for many of the esteemed granting panels. And so if you didn't get your grant funded, talk with Derek. Derek is awarded the University of Ottawa Heart Institute Clinical Science Investigator of the Year award previously. But of course, we know Derek from the point of view that he's been really a leading edge investigator in the field of precision medicine, and where he originally published the important observation of the CYP2C19 polymorphism on the metabolism of clopidogrel in patients undergoing intervention, the effect on platelet function. This was published initially in the Lancet. This was followed by the very large major global clinical trial in collaboration with the Mayo Clinic, the Taylor PCI trial that was published in JAMA earlier. And then he most recently presented a late-breaking trial session at the American Heart Association meeting that just concluded on the hot result of the rapid CABG trial. So to bring all this together and us up to date, Dr. Derek So today will speak with us on the topic of platelet quiescence and other potentials for more rapid CABG. Take it away, Derek.
Thank you very much, Peter. Hopefully you guys can see my screen.
Yes, we can see it. Great.
Perfect. Yeah, again, thank you very much for the opportunity to present at Research Ranks. Essentially, the basis of today's discussion is going to be on rapid CABG, which is the trial that we had just presented. But most of you know that the RAPID group is essentially a group of researchers and trainees, both here at the Heart Institute as well as in Montreal and Toronto. And we work collaboratively in terms of looking at specific questions surrounding antiplatelet therapies and personalized therapy. So essentially the following are my disclosures. The rapid CABG study is sponsored by CIHR and also by an Oracle grant through the Heart Institute. And then the rest of my disclosures are shown below. I will highlight on the bottom here that pertaining to what we're going to be talking about, I have worked with a number of diagnostic and antiplatelet companies. So the agenda today, I wanted first of all to discuss with everyone some basic concepts and tools when we come to antiplatelet research. And I think it's important for us to go through some of the basis in order to have a better understanding of some of the studies that I'm going to show you. We're going to discuss some challenges of bypass surgery among patients with ACS. Who are on P2Y12 agents, in particularly looking at bleeding outcomes, ischemic outcomes, and the timing of surgery. And through all of this, that really brings us to the rationale of the rapid CABG study. In particular, what I want to emphasize is that ticagrelor might be a bit different, both in terms of the pharmacodynamics and this concept of some pleiotropic effects. Then finally, we're going to go through the actual rapid CABG study and the next steps. I do want to acknowledge that a number of trainees within my team has really been contributing to a lot of the basis of what's going to be shown today. So let's start off with a case. So this is a very typical case of what we see in the cath lab. So this is a 64-year-old gentleman, essentially with a past medical history of hypertension, diabetes, and is a smoker. He describes a 1-week history of pain really with minimal exertion, and then on the day of admission comes in with prolonged rest chest pain of 20 minutes. By the time the first troponin is drawn, it was already positive, and the emerge doc proactively and rightly so started the patient on aspirin, ticagrelor, which is a P2Y12 inhibitor, heparin, as well as a statin. So a day later, we bring this patient to the cath lab, and this is what we find. In the right coronary artery, there is a 90-degree proximal stenosis, but it's severely diseased throughout that right. And in the LAD, or left anterior descending artery, again, diffuse disease and circumflex disease as well. Recognizing that this is a patient with diffuse disease, is a type 2 diabetic with TIMI3 flow in all arteries, this would be a patient that for sure would be better served with bypass surgery. But there are some challenges, and that's what I'm going to outline to you when we think about bypass surgery in this population. So let's take a step back. What is the scope of this problem? To give you an idea, this first statistic is actually from the AHA 2020 report. And in the US alone, there are greater than 1 million discharge diagnoses of ACS per year. Not surprising when we look at the Canadian population, which would be about a tenth of that in the US. From 2008, there was a CAI report, which was drafted by AstraZeneca, that they had over 100,000 patients that were hospitalized for ACS per year. It comes from multiple sources, but at least 10% plus of patients that come in with ACS subsequently require bypass surgery. So that really gives you an idea in terms of the scope of this clinical problem. Before we actually talk about some of these studies, I'm just going to briefly backtrack a little bit and review with everyone the players involved in terms of the different drugs, and in particular, how we actually study antiplatelet drugs with some of these tools. And it's important to go through this because it really enables everyone to have a better understanding of some of the study data that I'm going to show. So when someone comes in with acute coronary syndrome, typically they're treated with 5 medications. And when it comes to antiplatelet therapy, it's aspirin as one of the cornerstone therapies, and the other one is a P2Y12 inhibitor. And that's one of the receptors on the platelet cell surface. Currently in Canada, there are 3 available P2Y12 agents: clopidogrel in the far left hand, prasugrel, and ticagrelor. So clopidogrel and prasugrel are both thienopyridines, and I'm going to show you in terms of how the actual pathways of these drugs work. But ticagrelor is somewhat different in that it's a newer class of medication, and it's a direct inhibitor, and it also has this reversibility. And I'm going to talk to you later on about what that actually means. So here's the pathway in terms of the P2Y12 inhibitors. I'm going to draw your attention first of all. I'm going to see if I could put on my laser pointer here. In terms of clopidogrel and prasugrel here. So clopidogrel and prasugrel, again, are both prodrugs. So it actually requires a biotransformation in the liver, and then essentially that active metabolite then exerts its effects on the P2Y12 receptor. Okay. On the other hand, ticagrelor, shown on the bottom here, is a direct inhibitor. So it could directly inhibit that P2Y12 receptor without a biotransformation. So for sure, what this enables for a patient is that there will be a faster onset of action on the P2Y12 receptor, and at the same time, there's going to be more platelet inhibition. And especially with clopidogrel, it requires a two-step biotransformation, so that certain people might have some genetic factors in terms of loss of function alleles that further might affect their absorption and metabolism of the clopidogrel. So the main thing is, once we know about these drugs, is how we actually can understand the better mechanisms. So I'm going to show you and go through with you some of the tools that we have, both on the point of care testing and also on a lab testing in terms of platelet function. So these are actually all tools that are available here at the Heart Institute. The one that I actually use the most is the machine in the center here, and that's called a Verify Now P2Y12 analyzer. It could also measure aspirin responsiveness. Agridine is a newer company. And then if you actually use fast phosphorylation, you can also, with a flow cytometer, measure platelet function. So I'm going to actually take a study that Nikita Malhotra, who's the chief resident in cardiology, had done with me a number of years ago. And the reason I'm showing this study is it gives you an idea in terms of how the platelet function tools help us in terms of better understanding and bringing it to the clinical front. So this was a study that Nikita, again, did a number of years ago. And what you see here is the numbers. The PR2 is the platelet reactivity units, which is the measure of the Verify Now analyzer. And we have our two drug pathways here. So T is ticagrelor here, and PA2 is just a personalized antiplatelet regimen that we had based on pharmacogenomics. And the reason I wanted to use this study as an example is that there have been now validated cutoffs from clinical studies that when you take a PRU of under 85, these people have low on treatment platelet reactivity, meaning that the presence of the antiplatelet agent, when it's well inhibited, it increases the chances of bleeding. On the other hand, from an interventional cardiology point of view, high on treatment platelet reactivity, as shown here at 208, these patients are at increased ischemic risk. So obviously, it doesn't matter what type of study we're looking at. Ideally, you want patient in this green zone, so that in a zone where they are potentially protected against ischemic outcomes, but at the same time, not being at risk for bleeding. And obviously, this is going to be an important aspect when we talk about today's study. So again, the 208 and the 85 are shown here. So let's backtrack a little bit. I showed you the 3 P2Y12 inhibitors that are available. And essentially, ticagrelor right now is the first line agent when it comes to acute coronary syndrome. And this was all based on a study called PLATO. And the PLATO design is shown here. So they took patients that were that had non-ST elevation myocardial infarction or STEMIs, if they were bringing them for primary PCI, and they randomized them quite early up front. So patients were actually allowed to be treated even in the emergency room before they arrived to the cath lab. And that's important because from a usefulness point of view, obviously this would be important if it actually came out positive, which of course the study did. So patients were randomized to clopidogrel, as shown on the left-hand side here, versus ticagrelor, and the primary outcome was looking at a combined MACE, which is CV death, MI, and stroke. They also had safety outcomes. So first of all, the main outcome of the PLATO study is shown here. And what you see here is that by having patients on ticagrelor over clopidogrel, there is a reduction in overall MACE events. When we break this down in terms of the different categories, there are different components of that MACE, it's important that almost every single category is significant of ticagrelor being better than clopidogrel. And intriguingly, what you see here is when we look at total deaths in the PLATO, there is actually a mortality benefit. So certainly that is a very intriguing point, and that's why guidelines suggest this as the first-line medication to be used in patients with acute coronary syndrome. So number one, it could be used upfront before you get to the cath lab. Number two is that not only does it reduce MACE, that there is some potential evidence that there are mortality benefits. But not surprisingly, anytime that we think about a blood thinner, we have to think about that we're preventing thrombotic events on one side, which is what us as interventionalists are most interested in. But if the surgeons are taking that patient to the OR, the worry, of course, is bleeding. And as I told you before, just over 10% of all patients with acute coronary syndromes at some point might require bypass surgery. So let's talk about bleeding in ticagrelor, and I'm going to start off with some clinical evidence and then come to more intriguing mechanistic evidence. So this is from the main PLATO study. So overall, and not surprisingly, what you see here is that on this red panel, that there is an increased bleeding of ticagrelor over clopidogrel, and this is major bleeding in all comers. But the interesting thing is that when it comes to CABG bleeding, so keeping in mind when we treat these patients up front, the idea really is that the minority of these patients will require bypass surgery, but certainly some of them do. And when we specifically look at bypass bleeding, this is not statistically significant, and numerically, there's actually less bleeding in ticagrelor over clopidogrel. And certainly this was an interesting finding at the time. So the investigators in PLATO actually specifically looked at a sub-study of their surgical data. To give you an idea, overall, there were over 18,000 patients in PLATO. 1,899 actually underwent bypass surgery. As I told you, it's about 10%. And then they further broke it down in terms of patients that at least had one dose of study drug, were within, they knew the timing of when they stopped the drug when they went to surgery. And in this particular sub-study, they particularly were interested in patients that went within the first 7 days. And what you see on the right-hand side panel is the distribution of when patients went to surgery here. The majority of them went later. And to give you an idea, within that study, obviously they can't control if a patient had to go first day, but the suggestion was that try to wait at least 48 hours, but ideally to wait 5 days. All of this, keeping in mind, is non-randomized data. So basically, don't know why, but patient had to go to bypass surgery, either because they were having symptoms or because their physicians felt that this was the best time. But the large majority of these patients went between that 5 to 7 day period. Breaking this down further, when we look at the specific days of when the last dose of ticagrelor clopidogrel is, what you see here in terms of major bleeding is that essentially between the ticagrelor and the clopidogrel, the more potent agent did not actually incur more bleeding. There are several interesting trends when you look specifically at this table. Number one, and not surprisingly, when you take patients at 1 day or less, that there is a very significant risk of bleeding. And as you move away from that day 1 onwards, that bleeding drops significantly. The other findings is when we actually look between ticagrelor and clopidogrel, numerically, again, that there is less bleeding in ticagrelor patients compared to clopidogrel. So the question is, why might there be less bleeding? And one of the primary things with ticagrelor is what I had mentioned at the very start, which is that it's reversibly bound. So what exactly does that mean? Number one is that the degree of inhibition actually reflects the plasma concentration. And that essentially, we know that the ticagrelor is a faster onset, but at the same time, it also has a faster offset. And that functional recovery of the circulating platelets are present when that reversibly bound aspect kicks in. And this is a study from Paul Goebbels' group called onset offset. I'm just going to draw your attention on the left side. So basically, there are 3 curves here, people that were on placebo. The middle curve is people on clopidogrel, and the last curve are people that are on ticagrelor. At the loading dose, very quickly, there's a lot more potent inhibition in ticagrelor treated patients, and they treated them to a steady state at 6 weeks. At 6 weeks, what they then did was stop the drug, and what you quickly see is within the first couple of days, there's a very quick offset of that ticagrelor, and it actually goes over that clopidogrel curve within that 2-day period. The other thing that I think is important when we talk about what exactly reversibility means is that it actually off-bounds, but you cannot overcome the effects with platelet transfusion. And I've always been very impressed with this study here in that it's essentially taking one patient and they got themselves published in New England. And they had a patient that came in with a neurological bleed and transfused multiple units of platelets to see what would happen. And what you see here, it's first they transfuse 8 units and then 9 units, and there is a increase in terms of platelet count. But when it actually comes to P2Y12 inhibition, what you see here is that there is no change in that platelet inhibition when it comes to giving that platelet transfusion. And so the bottom line is that you cannot actually overcome the bleeding when you've treated someone with ticagrelor by giving platelet transfusion. So the question is, can we actually now think about it on the other side? Can ticagrelor actually, that during that cessation period, is it actually risky for patients? So the first study I'm going to draw your attention to is something that was done by Ali Pujabar, who was one of our trainees here before. He's actually an interventional cardiologist now in Kitchener-Waterloo. And Ali and I actually did a study called Capital Optocross. Now, the point of our study was actually to take a group of patients that for a clinical reason had to go from ticagrelor to clopidogrel. And what we were trying to do is to see, do we actually need to re-bolus someone with clopidogrel when they cross over, or can we just start the drug from de novo? And so in that intervention arm, we would give a 600 milligram of clopidogrel because it works on a mechanistically a different basis, and then went to 75 milligram. Whereas in the control arm, patients went on 75 milligram. And what you see are the curves of what we had seen in the study. So interestingly, once we stopped the ticagrelor, even though patients had a bolus in that top in the bottom curve here, and in the top curve, they did not have a bolus of clopidogrel. Between that 24 to 48 hour mark here, there is an at-risk period where essentially that offset of the ticagrelor comes up very quickly, even on patients that were on a steady state clopidogrel at that point. To further illustrate this point, we actually measured what percentage of these patients had high on platelet reactivity. So using that Verify Now machine that I showed you at the start and using that cutoff of 208, what you see here is that between that 48 and 24-hour mark, there is this potential at-risk period where when we're looking at stented patients, at least, there is this period where it bounces up very quickly and patients actually have high on treatment platelet reactivity. So they are much more at risk from a clotting point of view. So pushing this further, the question is, can we actually say that residual P2Y12 inhibition may be beneficial in patients going to bypass surgery? So Juan Russo, who was a trainee at the time, but is and right now is one of our interventional staff, along with Tyler James, one of our med students, actually had looked at a group of patients within the surgical database. And so with the help of our surgical team and anesthesia team here, we essentially pulled all the outcomes, looking at both ischemic and bleeding outcomes in people that went to bypass surgery who were on a P2Y12 inhibitor. And we actually found some interesting findings that I'll highlight here. So this was a cohort of about 500 patients. 95 of them were on ticagrelor, over 400 of them on clopidogrel. Our primary outcome was looking at combined ischemic outcomes of death, reinfarction, repeat revascularization, and stroke. And we broke them into time periods. So less than 72 hours after discontinuation of the drug when they went to surgery, between 72 hours and 5 days, and greater than 5 days. Okay. Although not numerically significant, there is this interesting trend that in that middle group, between 72 hours and 5 days, that numerically, there is less MACE, there is less deaths. And so this certainly was intriguing at the time. They actually had shortlisted Juan's presentation at JAC that year as one of the potential posters of interest. At the same time, when we looked at ticagrelor versus clopidogrel in that same cohort, what you see here is that in that first 72 hours, there were more clinical outcomes in the ticagrelor patients in blue. But again, in that middle time period, between 72 hours and 5 days, there is a reduction in terms of primary ischemic events. When we look at bleeding, what you see here is that when you go less than 72 hours, both groups have a high incidence in terms of bleeding, but that incidence drops very quickly in that middle period between 72 hours and 5 days. So we observed that, and at the same time, when we looked back at the sub-study in PLATO, they had also looked at a group of patients in terms of ischemic outcomes. Not surprisingly, patients that had to go within the first day had a very high mortality. So it's almost 10% mortality if you have to go the first day on surgery if you've had ticagrelor. Interestingly, between days 2 to 3, what you see in ticagrelor in black is that there's a substantial decrease in events, and that is much lower than those patients on clopidogrel. But by 5 days, that difference is no longer present. So that really brought us to an idea of a concept of platelet quiescence, that we see this reduced mortality despite using a more potent antiplatelet inhibition. And what we had to come up with is why might this be the case? Is it that there's an increase in terms of graft patency? Is it that the increased platelet effects after the patients come off ticagrelor, that post-operatively, the ticagrelor offset actually might be protective at that point? So we had looked up in the literature and we saw that there were several studies that actually had pointed the same thing. And so 2 of my trainees, Kiran Sarafi, who's a staff cardiologist in Australia right now, and Kojit Singh, also a staff cardiologist in Australia, we actually did a meta-analysis looking at all antiplatelet studies. And what you see here is when we looked at, and we looked at any type of more potent versus a less potent antiplatelet regimen. And it could be a P2Y12 agent, it could be a 2B3A inhibitor, and just aspirin versus clopidogrel. When we looked at non-randomized data, there was no difference. But the interesting thing is when we looked at any of these randomized studies, there again was this mortality difference that favors the stronger drug. So really pushing forth the concept that for some reason that's unknown, a more potent regimen may be protective. And this is actually a cartoon that Paul Gerbo had in one of his papers. And I think it's actually quite interesting or very noteworthy in terms of what we're talking about today. So someone comes with acute coronary syndrome, we treat them with a P2Y12 inhibitor to direct their platelet effects. But at the same time, what happens is that in someone undergoing bypass surgery, because we actually are opening up vessels, we're opening up chests, that there is an activation of both the platelet as well as the coagulation cascade, both of which ultimately would have platelet effects. So does the presence of these P2Y12 inhibitors actually help with some of the detrimental effects that surgery may be causing? But again, keeping in mind the bleeding versus ischemic factors. And so this we're going to come back to, but it's certainly very important. So the basis of rapid CABG is this, that we saw this clinical paradox. Why does a more potent drug which predisposes to bleeding may actually confer mortality benefits when patients undergo early bypass surgery? An idea or a main hypothesis when I first thought about this was, is residual P2Y12 inhibition creates this state of platelet quiescence, and that's actually provide an ischemic protection for ACS patients. So we came up with the idea of randomizing these patients early versus late, and I'll go over this in more detail. But we actually started with a mechanistic study sponsored by an internal Oracle grant to look at this, and subsequently we got sponsored by CIHR on the clinical study. And in terms of the Oracle portion, we were looking at the platelet function assays that I had shown you before. At the same time, we wanted to explore whether there are potential pleiotropic effects. And one of the things that ticagrelor does is that it changes the adenosine or plasma adenosine level, and that it's been suggested that may be one of these pleiotropic effect outside of platelet inhibition alone. So we had a clinical study built in with a mechanistic study. And we designed it initially as a vanguard, thinking that we could essentially collect our ischemic outcomes and ultimately look at ischemic outcomes. But in our first study, we were really looking at the safety aspects, which is the bleeding aspect, and to make sure that we were not endangering patients. So that is the basis of the rapid CABG study, which we were very lucky to be chosen at the late-breaking science trial, which we presented a couple of weeks ago. This was done out of here at the Heart Institute and also with our partners at the Montreal Heart Institute, again, sponsored by both the Oracle grant as well as CIHR. And this was also done in collaboration with the C3, which is a research network across the country. This is the trial organization of the study. Essentially, the basis, if you think about it, is that based on the evidence I've shown you, the suggested algorithm of when we go to bypass surgery as per the drug monograph is 5 days. And that's what the North American guidelines presently say, is that the ACCHA guidelines, as well as the Canadian guidelines, suggest waiting ideally 5 days after ticagrelor cessation before going to surgery. On the other hand, the European guidelines in their 2017 upgrades actually changed this to 3 days after cessation. And in the last 2 years, 2 of the Asian guidelines, both the Japanese guidelines as well as the Taiwanese guidelines, also changed it to 3 days. So there is this discordance between the international guidelines. So why might this be the case? I'm going to remind you, this is the same onset-offset study I'd shown you before. At 48 hours, when you stop ticagrelor here, it wears off. And in fact, the amount of platelet inhibition is below someone that's actually on steady state ticagrelor. And by 5 days or 120 hours, as shown here, it's equal to someone that's on placebo. So the basis of why waiting for 5 days in the original guidelines and why the drug makers want you to do that is that there will be no platelet inhibition left. Risk of bleeding for sure would be low. But thinking about that, our surgeons right now, most of them are comfortable operating on clopidogrel. By 48 hours, you're actually below someone that's on chronic levels of clopidogrel. So rapid CABG is physician initiated. It was multi-centered. And we looked at an early surgical approach at 2 to 3 days after ticagrelor cessation compared to 5 to 7 days. And these were in non-emergent bypass surgery. So if someone required surgery in the first day, they were excluded. Patients had to be greater than 18 and had to have received ticagrelor within the last 24 hours. Patients were excluded if they had stenting of the culprit lesion. So if it was felt that something had to be stented right at the start, they would have been out. Patients that required urgent surgery, again, would have been out. And patients that required concurrent valve surgery were also excluded. The hypothesis is that early surgery is non-inferior to delayed surgery when it comes to severe or massive perioperative bleeding. And the reason why we chose this is that there's quite a bit in the surgical literature that when we looked at these severe or massive bleeding, that these are correlated to post-bypass surgical mortality. At the same time, we picked a generous non-inferiority margin at 8%. And part of the reason is that we have to balance the concern of waiting and whether that incurs ischemic outcomes in these patients. This is the actual enrollment within rapid CABG. 72 patients were allocated to the early group and 71 in the delayed group. In both groups, there were patients after randomization that subsequently refused surgery, so that's why there are a couple excluded here. The next is our modified intention to treat analysis. So these were 71 patients that went to surgery and 69 in the delayed group. I will draw your attention down here. There were patients on both sides that went later than their assigned window, and that might be because of logistic reasons or medical reasons. At the same time, in the delayed group, there were patients that went earlier, and I'm going to show you the data on this later. So finally, because we were looking at safety as our primary outcome, we wanted to look at the per protocol analysis, meaning patients that were assigned to a time window and actually went to surgery at that assigned time window. The primary outcome was severe and massive bleeding, as defined by the universal definition of perioperative bleeding. And this is a score that's been validated to correlate with mortality when we look at class 3 or class 4 bleeding. And that's severe for class 3, massive for class 4. The baseline characteristics of our patients are shown here. There is no difference between the groups. These were high-risk patients with a large proportion of them being with diabetics. And when we looked at the reason for surgery, the majority was because of multivessel disease. In terms of surgical characteristics, this is shown here that the number of left internal thoracic arteries used or secondary arterial graft used were similar between the two arms, and the number of vein grafts used were also similar. We did do platelet function measures at the time that went to surgery and for the next 72 hours. And not surprisingly, when you actually looked at the early group, there is more residual platelet inhibition in that early group to the delayed group. And the median time of surgery in the early group was 3 days after cessation, and for the delayed group, 6 days. So these patients did go to surgery at their assigned interval. And when you look at the platelet inhibition, not surprisingly, the early group had more platelet inhibition. This is the primary outcome of the study. We had 4.6% of patients in the early group with class 3 or class 4 bleeding versus 5.2%. And this met our non-inferiority margin with a p-value of 0.025%, as shown here. We further broke it down in terms of different components of bleeding. When we looked at class 3, class 4, TIMI CABG, which is another bleeding score, and BARC4, which is bypass bleeding, and BARC5, which is fatal bleeding, no difference between that early group versus the delayed group. When we looked at both bleeding and transfusion parameters within that surgical period, there were no differences between the group. And these include things such as delayed sternal closure or the amount of chest tube drainage within that first 12 hours, patients requiring re-exploration. So none of these bleeding parameters were different between the two groups. And when we looked at transfusion of blood products, there were no differences between the groups either. The interesting aspect was this. So when we come to the ischemic outcomes, we can't look at it based on a per protocol, because in a per protocol, we want to actually have seen what happened to patients if they actually needed surgery earlier. And so the first group of ischemic outcomes I'm going to show you are things that happen prior to their assigned surgical dates. So in the early group, there were no events, but in the late group, almost 9% of patients had events, and these included myocardial infarction prior to surgery, recurrent angina, and one patient actually had ischemic VT that mandated earlier surgery. When it comes to 6-month data as shown here, overall, numerically, more events in that delayed group compared to the early group. Keeping in mind, these are hypothesis generating, as we were not powered to actually look at ischemic events. When we look at the median length of stay from randomization to discharge, it was lower in the early group compared to the delayed group. So it was 9 days in the early group compared to 12 days in the delayed group. So the summary of the key findings in rapid CABG are as follows. Early surgery at 2 to 3 days after ticagrelor cessation was non-inferior in incurring severe or massive perioperative bleeding compared to waiting 5 to 7 days. There were no differences when we looked at multiple bleeding scores between the two strategies. And in patients in that delayed group, they showed that there were ischemic outcomes that required earlier surgery. And this was something that was not observed at all in patients allocated to early surgery. Finally, early surgery had a reduction in length of stay by about 3 days. So rapid CABG is the first and only randomized study to look at safety of early surgery. And we found that by taking an early approach at 2 to 3 days after ticagrelor cessation, that this was non-inferior in incurring severe or massive bleeding compared to 5 to 7 days. So the question is, what are the next steps now that we've seen it? Certainly the hope is that this might influence North American surgeons and guidelines to reconsider and consider actually bringing patients earlier to surgery. But from a research point of view, I do think that there are next steps that we must take. As I told you, we have our built-in mechanistic study, which we're just starting to look at right now. And I'm just going to show you the potentials of this. So remember that this is, again, from Paul Goebel. When we look at these different drugs and looking at the pharmacodynamics, we're weighing the bleeding risk versus the ischemic risk. So do we actually have data with our platelet function data to say that, can we actually use platelet function to guide when people go to surgery? And this was something that a group in South America had tried to do, looking at platelet function testing. And so they looked at LTA, which is one of the platelet function measures, and used platelet function to essentially direct when patients went to surgery. Now, this is a study that was published in JACC. They showed that doing this approach was non-inferior and that patients went to surgery earlier. The problem is that this study only looked at patients that essentially had clopidogrel. So there were no ticagrelor patients. There were only 2 patients on ticagrelor here. And so this is definitely a future direction. And what we hope to do is with the platelet function data that we've collected in rapid CABG, that we could set some insights in terms of guidance of using specifically the Verify Now and in patients with ticagrelor when they should go to surgery. And to give you an idea, this is sort of some pilot data that we had done before, when we looked at PRU or platelet function data, one of the things we did suggest is ideally that after surgery that they restart ticagrelor. And to prove that we can actually measure this, here in blue is a patient that basically had a ticagrelor restarted after surgery, and very quickly that inhibition drops down. And that patient is again inhibited with the drug, so that you potentially prevent ischemic outcomes very quickly after bypass surgery, versus someone in green that did not get ticagrelor bolus. So our platelet function data might help us from a mechanism point of view understand this better. And we also collected fast phosphorylation through flow cytometry, and basically it shows exactly the same thing. The other thing that we did do is we did collect serum adenosine levels in our patients going to surgery in the Ottawa site. So this might be another avenue to provide more mechanistic understanding and to really bring about why there's this surgical paradox of more potent platelet inhibition being beneficial. So the final frontier, I think, really is this. So some of you might be aware that a couple of years ago, Deepak Bhatt had actually worked with a biotech company in the US, and it's quite fascinating. So AstraZeneca is the makers of ticagrelor. They had this drug on patent all of these years, and they never could come up with an antidote. But this private biotech firm actually created an antibody-based ticagrelor reversal agent. And here in the Verify Now data on healthy volunteers, they showed that patients were fully inhibited with ticagrelor, and when given the antidote, within essentially half an hour, they were able to bring that patient's platelet inhibitivity back to a state where bleeding risk potentially might be decreased. And so again, this is intriguing. They actually presented their one-arm study at AHA this year, and they're trying to get FDA clearance to release this drug early. But the question is, now that we've shown that early bypass surgery off rapid CABG at 2 to 3 days is safe, the question is it better to reverse it acutely and bring patients to surgery, or is it just as safe, if not better, to wait 2 to 3 days? Because by waiting 2 to 3 days, you might have enough platelet inhibition that if there is some ischemic protection, that might be an advantage. So I do believe that the study results from rapid CABG might enable that next step to for it to go against or be compared to a reversal agent. So finally, I just wanted to thank the different members of the RAPID team and the collaborators. And this includes, of course, my interventional colleagues, all the surgical group colleagues that have been very helpful, and especially Dr. Rubens and Ruel and Chan, who have all been quite instrumental in getting rapid CABG completed. And anesthesia group colleagues, and our study has been going on so long that we've actually had a few retirees, but essentially they have been very helpful in terms of the design of the study. And a great shout out to Dr. Wells and Lily and Mylin for the biostats help. And of course, my coordinating team here, they have been awesome in terms of getting these patients. A lot of the data leading up to rapid CABG has been with the efforts of my trainees. And then Marie, who is a platelet researcher in Montreal Heart, she has been a great collaborator and a research partner over the years, along with Dr. Tanguay, who is also an interventionalist in Montreal. So the last group I want to thank, of course, are the committee members. So our adjudication committee with Dr. Davies, Richard Davies, as well as Anthony Poulan, one of our fellows, and our DSMB with Garishner and Sophie Duroc, and most of all, of course, our patients for volunteering to help us out with studies that this would not have come into fruition without their support. So I'm going to stop here and see if there are any questions. And I really look forward to more discussion. And I do look forward to interacting with my team on a social basis. We haven't actually had an in-person party in a while. This was Christmas a couple of years ago, just before COVID hit. And hopefully we'll be coming back to more normality over the years. Thank you.
Oh, great. Fantastic presentation. Really exciting, and building really on a lot of very careful analysis, right, of a clinical trial data, gaining mechanistic insights, very meticulous incorporation of mechanistic components of the biology together, with the clinical question, and allowing to actually do the clinical trial, which is really very effective. It shows that you don't need 5,000 patients always to actually come up with conclusions. And I also saw on Twitter, there were a lot of congratulatory notes, but people were saying that in fact they have already kind of adopted a lot of this concept into practice, and so glad that now that you actually derive the evidence to support that practice. And so I think this is very exciting. So let's see. I think there's some questions. Yeah, please feel free to pose your questions, and also directly pose the question as well. And Dr. Ahmadi asked, when it comes to choosing between ticagrelor and the clopidogrel in the first place, and so nowadays, are there any factors to take into consideration, or to use ticagrelor for everybody?
Yeah. So if you go by both Canadian as well as international guidelines, ticagrelor would be the preferred agent over clopidogrel when it comes to patient with acute coronary syndromes. Much of that decision, because in Canada people do pre-treat patients upfront, and of course, because with our geography that lots of patients are at peripheral hospitals before they come to our institute, that decision largely falls upon either the immersed physicians or to the internists and cardiologists at the peripheral hospitals. But I do think that ticagrelor should be the #1 drug use in terms of upfront use. Sometimes we see patients where we look at the ECGs, or if there are some very high-risk features, when we say that patient might really be a surgical patient that might need to go to surgery immediately, you could make the argument that you treat that patient with clopidogrel and then cross them over to ticagrelor. But the bottom line is the majority of patients in Canada right now are treated with ticagrelor, and that's the right thing to do.
Great, yeah. And what about any secondary outcomes, in terms of, for example, stroke, or, subsequent, I guess there's no need for revascularization in these patients for these type of settings, any other, endpoints, besides the ones that's already captured in the primary endpoint.
Yeah, so remember the primary endpoint of rapid CABG was looking at bleeding only. So the secondary endpoints I showed were really the ischemic endpoints. Again, that ultimately is our hypothesis, is that a more potent platelet inhibition actually might be protective. But with our study being smaller, any of the ischemic outcome is certainly at this point hypothesis generating. However, I think a lot of the comments from both feedback during the AHA panel and also what we saw, of course, on social media, is that people do see these events and talk about them. The question is there the possibility down the road to really look at it on a much bigger basis? Because we did do some power calculations in order to specifically look at ischemic events. We're looking at almost 800, 900 patients to possibly get that difference between the two groups.
Yeah, for sure. I remember, a lot of people, as you mentioned, the panel as well as social media talk about whether it will be time, consider people, working together to develop a larger international trial. Yeah. Do you have a plans, or you think you leave that for other people?
I'll tell you one of the reasons why we decided to go from the vanguard and actually publish or going to publish our study is that with the reversal agent coming in, that might be a different strategy that people might adopt. And I think we certainly need the results of REVERSE-IT to be out there. And we probably need a randomized study at some point looking at essentially stopping the ticagrelor versus reversing it. And we had actually been in talks with the makers. They wanted to get their drugs out first, but this is something that we do foresee as a potential of what happens in the future.
Right, yeah, it's a different strategy, but just as relevant. And I think Ross Davies, who obviously, also was a big fan. Congratulations, excellent trial. And I guess maybe the last question I have is this something now we're going to adopt as a routine, or is this going to be, risk-based?
I think certainly our surgeons here, having gone through rapid CABG, are more comfortable in terms of going after that 2-day period. And people, I still get asked because they know I have the ability to do platelet function testing. Can you do some platelet function testing? But certainly, I think having that data out there is going to be reassuring for surgeons. The message is going to get out there. Next week, we're actually presenting at a CCS panel to talk about the late-breaking trials from AHA. So hopefully the messaging gets up there. And of course, the most important thing, and this is something that we hope to be able to do very soon, is to actually submit our data for publication, which we're just in the process of imminently doing. Yeah.
Oh, sorry, one more question. Hassan Mir, and a fantastic trial and the fascinating data. And any thoughts of pushing to 24 hours?
Yeah, so there, you can go earlier. I think if surgeons, and especially in the US, where litigation is always a concern, where the product monogram tells you to go at 5 days, now you're going into uncharted territory in terms of you're against every single guidelines, including the European guidelines. You're working towards, based on pharmacodynamics, that you might do that. There's one paper published right now that has looked at that. We're trying to essentially work with all the investigators that have got papers out there. One of my trainees is doing a meta-analysis on that. So we might shed more light in terms of the exact hour and timing. But right now, I don't think there's any data really to support going forward.
Great. Yeah. So thanks so much, Derek. I think it's really a tour de force and a very, very exciting, sort of building on a lot of foundational knowledge and, bringing it to fruition. And I'm delighted to see that, Oracle Funding was able to actually, sort of bring some of this forward to full-fledged CIHR funding and, the multi-center trial that followed. So really congratulate you on all these great efforts. And so thanks very much for joining us. Next week. It's Glenn Wells, who will be presenting his latest data. So take good care. And thanks again, Derek, for a fantastic presentation.
Thank you very much for having me. Bye.